Welcome everybody. We're just going to give a few more minutes to let a couple of extra people come into the room if they're joining us. Do though in the chat type in, let us know who you are and where you're joining us from, because we love to know who all the other people are on the calls. And that really helps as well when we're thinking about what we're saying and how we can draw on you. Great to see names of many of our students, which is lovely on here, joining us from around the world, which is fantastic. Just from the northwest of England's very important. Doesn't have to be as fancy as Germany or Guyana. I'm joining you all just from London, so you know, lost the sunshine we had last week, back to a reality of English spring. Hope you're enjoying your trip from Chile, Felipe. It's kids' time as well, so they're all deciding to come in just as we get going on this webinar, which is great.
Yeah, bring the kids.
Watch out, no. Yes, please. Great, well, I think we should get started because it is 6:34 and you've all made the effort to get here at this time. We know a lot of people get the link and then watch it afterwards, which is fantastic. And the whole of the webinar will be posted on our webinars page where we have the other ones from our series from last year. And we'll put the link to that later on in the webinar. I'm really pleased tonight to introduce Tim Harris, who many of you will know, I am sure. He is a very great colleague and the leader of our MSc in Emergency and Resuscitation Medicine at Queen Mary's University, which is the team that are bringing these series of webinars to you. For those of you who don't know Tim, he divides his time between academia and teaching and research and lots of clinical work too, but his main interests are around resuscitation, ultrasounds and education. He's currently working in Qatar and he's joining us tonight from Qatar as Deputy Chair for Emergency Medicine and Lead for Academic Affairs there. And he's also Professor of Emergency Medicine at Queen Mary's University in East London. He's worked in 43 hospitals in 11 countries and mixed training with travel for volunteer work in Africa, India and Samoa. I won't tell you how many years he's been in each of those, so I wouldn't want to do that to him, but he likes to base his career around major trauma centres in Australia, UK and Qatar. And the hospital he currently works in sees between 1,400 and 1,800 patients a day. And it's got a resus, which I think you've told me, Tim's got like over 100 beds or something crazy.
49, but we'll go for 100. We'll vote for 100.
Work for 100. Anyway, he's going to talk to us tonight about the evolution of RSI. I won't dare say whether that's induction or intubation or what LCI might join from. We do hope maybe there's a couple of anaesthetic colleagues on the call as well who will be able to get stuck in. And I'll be monitoring the chat, so if you want to ask any questions as we go through it, I'll keep an eye out for those and I can always interject with Tim. Otherwise, there'll be plenty of time at the end for you all to ask your questions there as well. Over to you.
Libby, thank you, and thank you for the introduction. So, ladies and gentlemen, absolute honour to be here, and I'm very grateful for you joining us. What I'd like to do for the next 35-40 minutes is just to discuss the way that rapid sequence induction and intubation has evolved over the last 70 years. Airway care has always been close to my heart, and the evolution of RSI really is cornerstone to what we do. And Tom Hurst, who now leads London's Air Ambulance, and I used to work together, and we talked a lot about the way that RSI had evolved, and those conversations really stimulated a lot of interest and stimulated me to look at some of the evidence. And today, what I'd like to do is revisit the original RSI, look at the first components. Then I'm going to start by looking at when we don't intubate and when we used to. And then I'm going to run through the evolution of the RSI. Now, I'm focusing on literature drawn from intensive care, emergency medicine and pre-hospital care, because that is the audience that we're dealing with here. And also because I think as you do your anaesthesia training, you'll be more influenced by the anaesthesia literature, and therefore most of you will be more cognizant with that. So let's go back to the original description. So RSI was described at rapid sequence induction, now rapid sequence induction and intubation, in 1970. The dominant paradigm at that time was the prevention of regurgitation of gastric contents and aspiration into the tracheal tube, with subsequent pneumonia and sometimes death. So the authors published what was then a 15-point checklist. Now I've edited that down a little bit just so it fits better into the slide, but they stressed the importance of checking kit and ensuring monitoring. Monitoring back then, of course, was ECG, no end tidal, no saturation. They highlighted the importance of passing a large bore nasogastric tube and emptying the stomach by suction, of removing dentures, cleaning the mouth. Much as today, they emphasised denitrogenation and pre-oxygenation for at least 2 minutes using 10 litres and a non-rebreather. They advocated intubation in a 30-degree head-up position using the sniffing position, i.e. neck flexed, head extended, also called the holding your nose over the pint position, and many other names. And we're going to come back to that later. Interestingly, they also advocated feet up. I'm assuming that this is simply to stop the patient sliding down the bed. They advocated the use of a defasciculating dose, or a small dose, in this case of D-tuberocurare, to minimise the adverse events of the fasciculations associated with succinylcholine. Because this was 1970, most of inductions were done with barbiturate thiopentone, and they did otherwise use scopolamine or halothane. Cricoid pressure was applied as the patient lost consciousness. Once the patient was unconscious, a dose of 1.5 milligrams of succinylcholine was administered. They did not use bag valve mask ventilation. They then placed the tracheal tube, released the cricoid, and proceeded on to surgery. So how has this changed? First of all, I think the key thing is oxygenation before intubation, and arguably resuscitation before intubation. ABC may be a really good approach, a structured approach to assessing our patients, but there are many, many times when ABC may not be the best answer to resuscitating our patients. We're all very familiar with the military version of CABC, stopping catastrophic hemorrhage first. And I think this widely applies when we're doing the risk-benefit analysis of who and when to intubate. One of the paradigm shifts over the last 10 to 20 years has been the de-emphasis of intubation as part of key practice in cardiac arrest. Airways 2, John Benger's superb trial with just over 9,000 patients, showed us that in paramedic practice, placement and ventilation was significantly more successful with a supraglottic airway device as opposed to a tracheal tube. And outcomes, in this case, the primary outcome was using a modified Rankin score of 0 to 3. So that's good outcome, not all survivors, but those are surviving with some meaningful neurological activity. Similar trial, similar audience, but from the US, compared the laryngeal tube with the tracheal tube. The outcome here, the primary outcome, was 72-hour survival. And in this trial, there was a significant advantage in favour of the laryngeal tube. The third key trial focuses on a doctor, paramedic, nurse team, and was performed in Belgium and France. Patients were randomised to bag valve mask ventilation or tracheal tube, and the primary outcome was 28-day CPC 1 or 2, so good neurological outcome, but judged by the cerebral performance category score as opposed to the Rankin score. And this trial showed equivalence between the tracheal tube and bag valve mask ventilation. Now, this trial was a non-inferiority trial, so it didn't, and I'm going to talk a little more about that principle later on. So overall, we can see that when I was training in the 90s and noughties, the key role around running a cardiac arrest was who was placing the tracheal tube. And now, of course, the emphasis on cardiac compressions and identifying reversible causes, and where we can ventilate and oxygenate the patients without a tracheal tube, we would do so. And certainly for my practice now, most of the patients I would intubate would be post-ROSC. I think the other area that's evolving is those that have a GCS under 8. I would love to have some evidence, and I'm a little embarrassed to talk about this because there's so little evidence about this group. Traditional teaching says GCS under 8, don't protect your airway, intubate. And as far as I can see, the ability to protect airway is only partially predicted by GCS. And we may see patients that are quite successfully managed without intubation. I'm looking at some patients with stroke, some patients with simple overdoses such as benzodiazepines. Let's turn our attention to the key features that determine the patients that we're providing care for. The original RSI was predicated around the risk of regurgitation of gastric content and aspiration into the tracheal tube. For those of us involved in critical care, be it pre-hospital, emergency or intensive care, our key concern is physiology. Most of the patients that we're intubating have a physiological reason. That might be a respiratory failure, it might be brain failure and coma, it might be cardiovascular failure and cardiac shock, or a mixture of all of them from toxicology. So the key thing that I'm evaluating is physiology and physiological risk, and how the act of intubation may impact on the pathophysiology of my patient. Of course, I'm still concerned about aspiration, but that's not foremost in my mind. I'm also concerned about anatomy and difficult intubation, but that's not foremost in the mind for the majority of my patients. So let's look at a couple of epidemiological studies. I'm going to start with NAP4, a fantastic observational piece of work led by the Royal College of Anaesthetists and the Difficult Airway Society. They looked at intubation both in and outside the operating theatre across the UK. And for us involved in intubation outside theatre, the key findings were difficult intubation is common, up to about 1 in 10, and they're poorly predicted. As we repeat our attempts at intubation, so our ability to oxygenate the patient falls, our risk of entering a can't intubate, can't ventilate scenario increases, and not surprisingly, those are associated with an increased risk of aspiration and then cardiac arrest. There's no doubt that acute airways are high risk. About 1 in 200 may need a surgical airway. About 1 in 300 will have a failed intubation, and about 1 in 100 will be can't intubate, can't ventilate. During the NAP4 survey, they described 10 airways in this acute care group and made some recommendations about the use of a scalpel bougie technique rather than commercial and placement of a cannula through the trachea. I'm not going to focus on front of neck access today. The authors identified some really important issues: failure to plan, in particular, failure to plan for failure, poor airway assessment, not knowing the kit, and unrecognised esophageal intubations. And there's no surprises that key recommendations were the use of capnography, checklists, practice using those checklists, agreeing an algorithm, agreeing a single approach for your institution rather than allowing individuals to choose their own approach, performing careful risk-benefit analysis, and of course checking your kit, knowing your airway trolley, your difficult airway trolley, and training for those rare events such as the requirement of front of neck access. I'm going to just turn to one paper from NEAR. NEAR is the National Emergency Airway Registry run out of Boston in the US. As far as I'm aware, it's the largest airway registry to focus on acute care and certainly emergency department care worldwide. Now, this is an observational data set of 15,700 patients that looked at risks of intubation in ED. Overall, if you were intubated in the ED, your chance of death was around 3.6%. And about 1% of those intubated had an arrest peri-intubation. That was defined as within 15 minutes of intubation after the onset of induction. And the key risk factors for that were hypotension, which was defined as a systolic of under 100, and that gave you an odds ratio of 6. Hypoxia, defined here as SATs under 90%, an odds ratio of 3, and crash airway, which of course is really a failure of adequate preparation. And I'll say at the outset, I think crash airways are very rarely required. Most intubations performed in the emergency department and critical care, we have time to adequately assess our patients and adequately prepare our team. So since a key risk factor here is cardiovascular collapse, I think it makes sense to try and look at that in more detail. So what can we do to minimize the risks of cardiovascular collapse peri-intubation? So first of all, resuscitation before intubation. I'm going to come back to that in the next couple of slides, but this would involve adequate volume, be it with blood products or crystalloid, perhaps starting inopressors, and above all, an echo assessment. Echo is the key to identifying risk of cardiovascular collapse. Do you have a poorly performing left ventricle, or worse, do you have a performing right ventricle and acute cor pulmonale? We know one of the most high risk intubations is people with right ventricular failure. Now that might be acute from a PE or acute on chronic from underlying respiratory disease. So resuscitation before intubation. What we're trying to do with resuscitation, of course, is ensure adequate oxygen supply, DO2, to all of our tissues. And oxygen supply is a product of our cardiac output, the amount of oxygen carried by each hemoglobin molecule, the number of hemoglobin molecules or grams of hemoglobin we have, and their saturation. And of course, cardiac output depends on venous return. And now, venous return is a real complex thing, but in part is dependent on our muscle pump. So as we move our muscles around, we return, that the pressure helps augment venous return. And our respiratory pump, as we breathe in, that negative intrathoracic pressure sucks blood into our superior and inferior vena cava, augmenting venous return. And we just consider that the lowest pressure part of your cardiovascular system is your right atrium. Pressures are often only 0 or just above 0. And the right atrium, therefore, is exquisitely sensitive to changes in intrathoracic pressure. And small changes here can have a dramatic effect on venous return. And of course, as we induce anesthesia and intubate our patients, we get rid of our muscle pump, venous returns reduced. We get rid of our respiratory pump, venous returns reduced. We alter the venous resistance. And of course, we're often dealing with patients that have an inadequate circulating volume. The drugs we use to induce anesthesia may be veno or vasodilators, so reducing the apparent venous return by changing the volume of distribution for our circulating volume. And of course, many of those drugs reduce the power of cardiac contraction. So overall, the effect of intubating patients may well be to impair and reduce oxygen delivery. And indeed, we observe a high mortality in patients in extremis. I've quoted some figures from London HEMS, but we could look at other figures from patients with profound hypovolemic shock, where the active intubation may take a patient with teetering on the edge of their reserve, and the active intubation may see a loss of cardiac output because they no longer have adequate venous return for cardiac output. Now, of course, oxygenation and rapid sequence intubation is an absolutely core part of resuscitation. Adequate oxygenation is, of course, what we're trying to do, but there are plenty of ways we can oxygenate our patients without intubation, and it may be that delaying intubation until we've optimized our patients improves safety. So let's have a look at large trials that may have touched on this. So when I was training anesthesia, I was told that I should always hang a bag of fluids and I should drip that bag of fluids in while I performed intubation. The idea being that the increase in preload from that circulating fluid may go some way to mitigating the adverse effects of positive pressure ventilation and induction agents. This is a randomized controlled trial in 8 intensive cares and 1 ED on 337 patients. It's performed in the US. And they wanted to see the effect of 500 mils of crystalloid run in rapidly peri-intubation against no crystalloid run in. Now, their primary outcome was an arbitrary one made for the paper. They called cardiovascular collapse any systolic pressure below 65, any use of vasopressors within 2 minutes of induction, any cardiac arrest or death within 1 hour. And that primary outcome was not affected by the infusion of fluids. Now, of course, this is not targeted physiology. I'm not putting this up to mitigate the comments I made earlier, although I'd be very interested to see what you in the room think of this. I was advocating a targeted risk-benefit analysis and a targeted assessment. What this paper tells us is that on average, dripping fluid in while we're intubating, on average, does not improve outcomes by preventing cardiovascular collapse. So the next thing on our risk factor was hypoxia. And this is a big deal. 1 in 3 emergency intubations in the ED suffer from hypoxia. So the original description of RSI was 3 minutes of denitrogenation, no bag valve ventilation. How has this changed? What do we do now? So I think the maximum is oxygenation before intubation. And many of us, particularly through COVID, were intubating people directly from NIV, directly from high flow nasal cannula. Many of us had adopted a technique where we would use active bag valve mask to continue to ventilate patients after induction of anesthesia, albeit at slow breaths. And then, of course, we've got the role of apneic oxygenation. So apneic oxygenation, that is the continuous flow of oxygen through cannula placed in the nose through the entire peri-intubation process, relying on greater uptake of oxygen versus of CO2. So we get a flow of oxygen down through the nose and into our lungs. Now, studies performed in the operating theatre have shown that the average apneic time and the average lowest recorded saturation are significantly improved by apneic oxygenation. The problem is, the sicker you are, the less effective this is. And the larger your shunt fraction, the less effective this is. Your shunt fraction is the volume of blood that does not pass through the pulmonary circulation in contact with the alveoli. So the blood is moving from the right to the left heart and at no time can come in contact with oxygen. Of course, if blood don't go through alveoli, it doesn't matter what you're putting into the alveoli, you're not going to make it more oxygenated. The next point on apneic oxygenation is to highlight the diversity of how we can achieve that, varying from a couple of litres through to 50 or 60 litres through high flow nasal cannulae. And it will come as no surprise to you to learn that higher volumes are more successful in prolonging apnea time and minimizing desaturation. Just a quick reminder, don't use your nasal prongs for this because they're really only rated for 5 litres, and that is a homeopathic dose of oxygen in this setting. So what do we know about apneic oxygenation in the emergency department? This is a systematic review and meta-analysis published around 5 years ago. These authors identified 9 studies. They included 4 RCTs and just under 2,000 patients. Now, these studies were performed pre-hospital, in ED, and in ICU. The primary outcome here was clinically significant hypoxia. Now, the problem is that there was heterogeneity in the papers. Different authors had defined clinically significant hypoxia as a different amount. Now, most were either saying 90 or 92, but there were others as well. For the meta-analysis, the authors simply said, we'll take whatever the paper did and call that clinically significant hypoxia. And the use of apneic oxygenation reduced the risk of hypoxia by around 1/3. And interestingly, certainly I wasn't expecting this, but they reduced the risk of death too. What about this issue of bag valve mask ventilation? So the traditional RSI advises and teaches no bag valve mask ventilation because you don't want to distend the stomach as you squeeze that bag, thereby arguably promoting regurgitation of gastric contents. This has been explored in one randomized trial. It was published 3 years ago in the New England Journal. The authors recruited 400 patients from intensive care and randomized them to either bag valve mask ventilation with 15 litres of oxygen and a PEEP valve set at 5 centimetres of water versus no bag valve mask ventilation until the saturations fell below 90%. Now, the key thing here is that the rate of aspiration did not differ. It was numerically lower in the group that got bag valve mask ventilation, but statistically insignificant. Now, the primary outcome of this study was what is the lowest median saturation in each group. The lowest median saturation in those randomized to bag valve mask was 96, and that was significantly higher than 93% in those that did not have ventilation unless their sats fell below 90. Perhaps more important is their secondary outcome, which looked at critical hypoxia. They defined critical hypoxia as under 80%. And the group, the patients randomized to BVM had half the rate of critical hypoxia as compared to the control group.
And Tim, somebody has said in the chat that from experience, their nasal oxygen prongs will deliver about 50 litres per minute if forced as well.
Yes, so what I was putting there was what the manufacturer advised and what they're rated to. I think there's many times in medicine when we choose to use kit in a way that moves against the manufacturer and adapts them. But we can come back to that and discuss further at the end. I'd be interested to hear of people's experiences. So now I'm going to turn to patient position. So the original RSI did promote head up, feet up. In ED now, a fair amount of literature has described the ear to sternal notch. So this is an adaptation from sniffing position where we're lining up the tragus of our ear and having it anterior to the sternum. And rather than just simply put a pillow or rolled up sheet or whatever under the head to elevate the trachea, we're ramping the patient. So we're placing a variety of material under the upper torso and up the shoulder, and then customizing the patient's position till the tragus is anterior to the sternum. So what research has we got in this? This is a meta-analysis of 6 randomized controlled trials. 4 of them compared sniffing position and 2 of them much smaller trials, ramping position with simple head extension. Now, I'm going to come to the key primary findings on the next slide. I'm just going to focus on a couple of interesting secondary points here. Now, the authors looked at the IDS, the intubating difficulty score. So this is a composite score made of 7 factors that are associated with difficult intubation, whether you needed to manipulate the larynx or not, the number of intubation attempts, the Cormack-Lehane score, the number of different devices used to intubate and time. And so it gives us a sort of composite measure of difficulty of intubation. And this was significantly lower in those that had sniffing position or ramp. And the effect was most prominent in those that had a predicted difficult airway. And the authors concluded that the best position to optimize sniffing position was ear to notch. And of course, in sniffing position, we are trying to line up our airway axes to give us the optimal view of the larynx. And one of the problems with this meta-analysis was the way that was achieved is different. So the way sniffing position was obtained in each paper varied. Some used soft pillows, some used hard rubber, some used rolled sheets, some used bag of salines. The height of occiput may be left to the practitioner or defined as 3 or even up to 7 centimeters. So there is heterogeneity behind these trials. Now, what the authors also reported was the Cormack-Lehane score did not differ. I think it's very important to understand that the inter-observer reliability of reporting Cormack-Lehane score is hugely bad, and that plagues some of the research in this area. But 2 harder endpoints, primary success and time to intubation, did not differ. So we can conclude by using sniffing position or by using a ramp position and ear to tragus, we make the act of intubation easier as judged by this composite score, and we improve outcomes in difficult intubation or predicted difficult intubation, but overall on average we don't improve success rate or reduce time. So let's go visit this head up, torso up. originally described as an intrinsic part of the RSI. Certainly when I was training, I was taught to intubate patients lying flat, not least of all because the beds we were intubating them on didn't bend, so we didn't really have a choice. And I'd be interested again at the end to see how many of you are using backup position. So this is a study from Wales. It's a before and after study. It looked at 374 patients supine and in sniffing, and 407 patients after the introduction of backup at 25 degrees. Now 25 degrees is chosen because this has minimal effect on output. It will not impair cerebral perfusion. It may have some benefit of lowering ICP, but the main benefit we're concerned with here is allowing the diaphragm a greater excursion and knowing the weight of the bowels to fall away from the diaphragm, hopefully improving the RSI and improving oxygenation. Now, the key message in this observational study is the first pass success rate was about 90% in both. However, the time to place the tracheal tube was slightly shorter in the backup ones, and there were fewer laryngeal repositionings and manoeuvres. Both of those were significant. There was no difference in the POGO score, that's the percentage of glotting opening, the proportion of the larynx you can see at laryngoscopy, or the Cormack-Lehane score, with which I'm sure you're all familiar. Now, there is a protocol published for a large randomized trial to explore this in France. I believe it started recruiting. I believe it should finish recruiting by 2023. The primary outcome is the proportion of glottic opening, and their main secondary outcomes are the comfort of the intubator, the laryngeal view, and the number of ancillary attempts and kit. So let's move on to induction agents. Now look, there are conferences and we could spend all day talking about induction agents. I think all of us would agree that the safest induction agent is the one with which you are most familiar. But for the purpose of this talk, I'm going to just focus on etomidate and ketamine because they are by far the most common agents used within emergency medicine, pre-hospital care. I know certainly in UK anaesthetic experience, when I looked at surveys, propofol remains by far the most common in emergency anaesthetic practice. I'm not going to go into that today in the interest of time. So this is a Cochrane review, and this review explored the evidence for harm from etomidate. As you all know, etomidate affects the 11-dihydroxylase and therefore reduces the steroid axis, and that reduction in steroid synthesis and steroid axis arguably interferes with the stress response and may cause death. And we know that etomidate as an infusion medication in an intensive care setting is associated with adverse outcomes. However, this Cochrane review, looking quite small, only 772 patients, found no evidence of mortality increase associated with the use of etomidate as an induction agent. There's no surprises that it found an association with significant adrenal suppression, but that didn't translate into any difference of SOFA score, i.e. composite measure of organ dysfunction and failure. We do have two randomized trials that have compared ketamine and etomidate head-to-head. So this is another large French trial. It randomized patients that needed intubation in the intensive care, emergency and pre-hospital environment, and their primary outcome was SOFA score day 1 to 3, so an organ dysfunction primary outcome. They found no difference in the composite measure for etomidate or ketamine. They did look at mortality, and there was a consistency that those intubated with ketamine had a higher survival, but this was nowhere near significant. Second paper is performed in the United States. So this is a trauma center, single center randomized trial. These authors noted from their audit data that there appeared to be a signal favoring ketamine over etomidate at 1 week. They therefore performed a randomized controlled trial of etomidate at 0.2 to 0.3 milligrams per kilogram versus ketamine at 1 to 2 milligrams per kilogram. And indeed, at day 7, there was a significantly higher proportion of patients surviving that had been induced with ketamine as compared to etomidate. However, over time, that gap narrowed, and while it was still numerically higher in ketamine, by day 28, which is as far as they followed the patients, there was no significant difference. And all their secondary outcomes, looking at time in ICU, time ventilated, and organ dysfunction, was not significantly different. I'm now going to come on to delayed sequence intubation. Now, this was very popular on social media and much tweeted about some years ago. And I was very interested because, like many things in my life, this is something that London HEMS taught me reasonably early in my training. So we're talking about the use of sedation to control an agitated patient to allow us to pre-oxygenate them, to place monitoring, to obtain IV access, and to place them in a safe position. And the only published trial I can find using the word delayed sequence intubation was by Scott Weingart and colleagues back in 2014. This is a 5-center observational data set, 4 US and 1 center in Denmark. They described the course of 62 patients, and these patients were sedated with ketamine, 1 milligram per kilogram, and then half that as aliquots as required to allow pre-oxygenation. Their key findings are that by sedating the people prior to intubation, the oxygen saturation did increase from 89 to 98%, and there appeared to be no adverse events as a result of this. And I think this is now reasonably common observed practice. So, paralysis, ROC versus SUX. And just like induction agents, you could dedicate a day or even a conference to this debate. ROC, rocuronium, is a cleaner, newer agent. It has less adverse events. SUX is, without a doubt, a dirty drug. It increases potassium by around 0.5 millimoles. I think all of us have seen that precipitate cardiac arrest in patients with an unexpected underlying and unmeasured hyperkalemia. It increased intragastric pressure, it increased intraocular pressure, and intracranial pressure. The fact that it's got a short half-life has been purported as an advantage. So, well, the patients can regain spontaneous respiration, so the risk of hypoxic damage is mitigated. I think in the patients who are intubating in intensive care, pre-hospital and ED, that is a moot argument. Most of our patients are going to be critically hypoxic long before that 8-minute time. So what do we know about this debate? So this is a Cochrane review of 50 trials with over 4,000 patients. And these trials were performed in the operating theatre, in ED and ICU. And SUX, and they used doses from 1 milligram and above, and for ROC, they used doses of 0.6 and above, so lower doses than many of us would use of both drug, but of course this included higher doses. And the headline here is that SUX and methonium was associated with better intubating conditions, both excellent and acceptable, and that this appeared to be synergistic with the use of thiopentane. So what about critical illness? So this is a multi-site randomized trial of 1,248 patients who had anesthesia induced with either ketamine or etomidate and were intubated using a direct laryngoscope. Patients were randomized to rocuronium 1.2 milligrams per kilogram or succinylcholine 1 milligram per kilogram. Now, I guess many of you in the room would say, oh, that's a lower dose of SUX, I'd use 1.5 milligrams. Oh, the trial risks being biased against SUX for that reason. Now, this is a non-inferiority trial, a design I must say I do not enjoy reading, because that means the authors don't report that one was better, they just say that one was inferior. So the conclusion here is that rocuronium is not inferior to SUX because it was within 7%, which was their a priori preset criteria for non-inferiority. That's a big mouthful, and that's why I don't really like non-inferiority trials. I'm too simple to really understand them. This trial reported that excellent intubating conditions were identical in the two groups, and adverse events didn't differ between the two groups. So we can see there is a weight of evidence that suggests succinylcholine at a dose even as low as 1 milligram per kilogram provides better intubating conditions than rocuronium across a broad range of patients in a broad range of environments. The question we all have to ask is that improvements in conditions worth paying the price for the numerous adverse events of sucks? What about difficult airways? So NAP4 taught us that difficult airways are common, up to about 1 in 10 in anaesthesia outside the operating room. And one of the recommendations of NAP4 was that we should predict those difficult airways with more caution and care. The question is, can we do it? So we know that a difficult airway can be defined. I have no idea what all that writing is. Was that me? All those little green lines? I'm sorry, that's just appeared. So a difficult airway is defined as experienced intubator needing more than 2 attempts to place a tracheal tube. As we attempt more intubations, so the risk of cardiac arrest, aspiration, hypoxia, can't intubate, can't ventilate increases. The problem is around half of difficult airways in our set of patients are not predicted. So why might this be? This is a really interesting paper. This is Steve Green and his colleagues from the US. They did a systematic review of the role of Mallampati in the ED. And one part of that systematic review was looking at its role around intubation and difficult airways. The authors reported 2 key points. One, you cannot sit up and assess your Mallampati in around half of patients in the ED. And 2, that the inter-observer reliability, at least among emergency physicians, but I think also among anaesthetists, is poor. So this doesn't appear to be a practical tool. Now, how good are the major tools at predicting difficult airways? This is a reasonably recent Cochrane review. It looked at the modified Mallampati, the thyromental distance, sternomental distance, and mouth opening. I want you to focus on the 3 columns to the right. DA, difficult airways identified, DA, difficult airways missed, and unnecessary overcalls, i.e. patients where the tool said, it's a difficult airway, but actually it wasn't. So for modified Mallampati, if you've got an incidence of, a prevalence of 10% difficult airways, which is what NAP4 tells us we could expect, then 5 of that 10 will be identified by Mallampati, but it will identify 18 unnecessarily. 4 will be identified by thyromental distance, but it will call 10 who were not difficult airways. Sternomental distance will call 7 and overcall 7, and mouth opening will only call 2 and overcall 5. And if you try to mix these scores together, as we do in things like the lemon, then the proportion of patients overcalled as unnecessary difficult airways increases and increases. So I wish we had a good tool to predict a difficult airway, but at the moment it seems that the key reason why we don't call many difficult airways is simply we are not good at predicting them. And I'd love to hear your experience and discussion as we get to the end of the talk. So let's move on to the video laryngoscope versus the direct laryngoscope. Now, the key advantage of video laryngoscope is we have a choice of blade. We can have a Mach 4, as you can see on the top, or a Mach 3, or a hyperangulated blade that really brings that high anterior larynx into view. And I think research and experience suggests that the introduction of a video laryngoscope has made the difficult intubation a much rarer event than the past. And the problem now is less, oh, I can't see the larynx, I can see it, but I can't get my tubing because it's so high. So at the moment, video laryngoscopes account for around half of all intubations in emergency department. This is a US biased figure. This comes from the NEAR database. Most of us would use a stylet with the hyperangulated blade. And again, I'd welcome comments from all of you experts in the audience, quite simply because bending a bougie to maintain the angle in the plane of a hyperangulated tube is difficult, and the bougie tends not to hold that position well, which sees the bougie hard to get high enough to get into the larynx. Video has a number of other advantages. One, medical legally, we can record the intubation. Two, we can share the learning with juniors in the room. However, there is a price to pay. To get a 90% success rate, you appear to have need more experience with the video at 70 intubations versus 50 for the MAC. And that's why for many emergency departments, we choose to say as a priority, a priori, we will teach one or the other. Now, people outside anaesthesia will never have the volume of experience of our anaesthetic colleagues, and therefore it's far more sensible that we become reasonably expert with a few drugs and a few tools rather than try to become reasonably expert with more of them. So how is the evidence base for this? This is a UK paper, and these authors compared video to MAC. They did a meta-analysis of all RCTs and quasi-RCTs in any setting, in the operating theatre, in the ED, pre-hospital and ICU. And this has been well studied, 64 studies, over 7,000 patients. Overall, the meta-analysis showed that video laryngoscopy had a significantly lower rate of failed intubation. And if you just took patients with a difficult airway out, that finding was even more prominent. First pass success rate was not significantly better. So if you had if your larynx is easy to see, it doesn't matter what you do, you're going to intubate it most of the time. And since most of the larynxes most of us are going to see are straightforward, that's no surprise. And they also reported that trauma to the larynx was reduced by the use of the video. What about focusing on the ED studies? So this was published a couple of years after that last meta-analysis. So while the last meta-analysis included 3 ED studies, this includes 1,000 patients. Oh, we've got somebody joining the room. Now, if we look at those 5 studies, the proportion of patients that have a successful first pass intubation is not improved by video. The proportion of overall success is not improved by video. So we're finding differently than we did in that overall meta-analysis. However, the proportion of patients that require esophageal intubation, the proportion of patients that unfortunately have their esophagus intubated is reduced. So another interesting debate is the use of bougie or the use of stylet. So bougies have been with us since 1949. What a beautifully elegant, simple device to improve intubation. Both bougie and stylet have their advocate and fans, and let's look at the evidence for one or the other. So this is a randomized control trial, again performed in France, of just under 1,000 patients randomized to intubation with a direct laryngoscope with a tracheal tube loaded with a stylet, or a tracheal tube with no stylet. And the headline here is that the stylet improved the rate of first pass intubation from 71.2 to 78.2%. What that means is for every 15 intubations, you achieve one at first pass that you didn't achieve otherwise, which is, I think, a high enough figure to affect any of our practice. What about bougie versus stylet? I'm going to focus on 2 large randomized trials by the same author. This is David Driver and his group, and this is a trial published back in JAMA. This is a single-centre trial of 757 adults and involving 50 emergency physicians. They're intubated with direct laryngoscopy using a MAC blade. The first pass success was 96% if you used a bougie and 82% if you used a stylet in patients that had one or more predictor of a difficult airway. Overall, in all patients, it was 98 versus 87%. The bougie was associated with a slightly longer, just 2 seconds in this time to intubation, and all of the adverse events recorded were equal between the groups. So this randomized trial finds firmly in favor of bougie after stylet. Now, the same author then did a randomized trial over 7 EDs and 8 ICUs. Now this time, the majority of patients were intubated using a video laryngoscope. The first pass effect was lower here at 80% and 83%, and there was no difference whether you used a bougie or a stylet. Again, adverse events were not different, and the time to intubation was quicker if you used a stylet. So why do we see these two trials offering us different outcomes? First of all, in the first trial, and that single center, most doctors used a stylet as their preferred tool. So they had experience of the stylet. In the second trial, the mean experience with the stylet was as low as 10. Bougie was as low as 10. Secondly, in the second trial, they had a different definition of first pass intubation. In the second trial, first pass was defined as you got the bougie in first time and the tracheal tube. So if you slid the bougie in and just couldn't quite get it into the larynx, maybe you slid down the esophagus or went off to one side or the other and pulled it back 3 centimeters, reinserted and got the larynx, that was 2 passes in the second trial. So that's why first pass is lower. What about cricoid pressure? Now this is an area where I do have bias. I think cricoid pressure is dead, and I'm very interested to be shouted down and for you to provide evidence otherwise as we come to the end. So cricoid pressure, the occlusion of the esophagus by providing pressure with a defined force on the cricoid ring, occluding the esophagus, stopping the regurgitation of gastric content during intubation. Now, this was introduced and became widespread in practice on the basis of just single pieces of observational data by the describer and with no randomized trial. And it's a lovely description and an elegant idea, but there are a number of issues. One, imaging studies show that when you press your cricoid down, you don't occlude the esophagus, but the esophagus slides out one way or another. 2, there's numerous reports of aspiration despite cricoid pressure. 3, it's really hard to apply 30 newtons during laryngoscopy. It's hard to apply it anyway, and it's hard to train people to do it well. Also, we know that cricoid pressure lowers the barrier pressure. That's the pressure between your stomach and the lower esophageal sphincter. And if that pressure falls, you're more likely to regurgitate your gastric content. We also know it's harder to put in supraglottic airways. It's a worse laryngeal view, and it's harder to bag valve mask, and you can show lower tidal volume. So there are a number of disadvantages of cricoid pressure. What does the evidence show us? So this is a large randomized trial, again performed in France. This is 10 centers. It's performed in an operating theatre of patients that required an operation and rapid sequence induction of anesthesia. 3,472 patients recruited in 10 centers. Now, the primary outcome here was aspiration, and this was assessed in 2 ways: clinical observation during laryngoscopy and aspiration of the trachea. And the headline here is 1, aspiration was rare, and 2, it was absolutely equal whether cricoid pressure was used or not. Authors looked at some other important components. Time to intubation was longer if you use cricoid pressure. The view, as assessed by Cormac-Lehane, was poorer if you use cricoid pressure, and the proportion of patients with a difficult intubation, i.e. more than 2 attempts, was greater if you use cricoid pressure. So overall, we find in the one large randomized trial that we have, there is no benefit of altered aspiration. Aspiration is pretty rare, and there are some potential harms. So let's end this talk where we began. I think, first of all, we pay homage to the fact that the RSI has been part of medicine for 70 years. And if we look at the way it's changed, I think it's interesting to see how much they got right, and also how much has changed. And of course it's changed. We've been doing medicine for 70 years. If it hadn't changed, that would be a very, very sad state of affairs, both for technology and for randomized trials and accumulation of evidence. So they said, check your kit. We checked the kit. We're lucky now. Our kit check includes saturation probes. It includes end-tidal capnography, large bore suction, and pre-anesthetic emptying of the gastric contents. Certainly isn't part of my practice. I have done it, but it's certainly something I could count in one hand, and I'd be very interested to hear your take on that. Cleaning the mouth, I don't think that's part. Removing dentures, I think most of us would leave dentures in because it promotes a better seal of the bag valve mask. Denitrogenation and adequate pre-oxygenation, absolutely. Oxygenation before intubation. However, now we know that bag valve mask is probably safe, and the use of NIV or high flow nasal oxygen to intubate patients at really high risk of hypoxia can minimize that. The head up to 30 degrees was described, appeared to fall from vogue, and is now in vogue again. And indeed, many of us during COVID were pre-oxygenating our patients sitting bolt upright and only lying them down right at the end to 30 degrees to do all we could to maximize oxygenation in that critically unwell hypoxic group. Defasciculating doses of what was then D-tuberculari, now maybe ROC or whatever you choose, that's not part of my practice. I'd love to hear if it's part of yours. I can understand the theoretical advantage of minimizing the adverse effects of fasciculation from sucks, but I've not seen really good evidence around that to make me change my practice. The original RSI was described with thiopentone for many reasons that we didn't discuss today. Thiopentone would be a drug that we would not like to use in our physiologically unstable patients. Succinylcholine remains the drug used for paralysis with the best view. And as we discussed here, the cleaner rocuronium may be seen as a better choice by many of you simply because of the adverse effects associated with succinylcholine's use. So I would like to thank you very much. I really enjoyed preparing for this talk. I look forward to comments and feedback. And I came out of a sim centre a little while ago, and I was intrigued to see that our stage blood had a zesty mint flavour. We weren't doing vampire scenes, but it was interesting. Have a look at your stage blood. Is yours flavoured too? So Libby, I'm going to hand back to you, and thank you for chairing, and thank you all for being here.
I'd hope that mine might be garlic flavoured to ward off the vampires if it was just stage blood, if they didn't all come in for a little catch up. Thank you so much, Tim, for that. Wow, that's really a lot of information there for everybody to try and sort of take on board. And there's been some few little active side discussions going on throughout that. Do you want to stop sharing your screen maybe, Tim? And then we'll just
sure
screen. That'd be great. So I think one interesting consideration that's come up a couple of times is obviously the difference between the low income and the low resource settings versus, you know, what we have in higher resource settings. So some of our colleagues saying actually in their setting, you know, they can't intubate people just because they've got a GCS less than 8, you know, because actually they still don't have the resources in order to manage that. And I think it's really sort of bearing that in mind and how we sort of share knowledge, but also help to improve services worldwide, isn't it? And then the other one in terms of that was the lack of video laryngoscopy, you know, maybe in other places, and how these things we've learned to take for granted where we are, whereas maybe it's still less seen. There was a question for you to ask about delayed sequence induction, and then you managed to answer it about 3 minutes later, so that was fantastic. So you preempted the desires of the people listening. And then there was a link to a paper about atracurium as an RSI agent from 2020 in Thailand. but the conversation managed to show us that possibly at 1 milligram per kilogram, still 50% of the patients were coughing and bucking, and maybe that wasn't ideal. So we're not sure that we were all sort of rushing to follow that paper's guidance straight away. If you've got questions for Tim, do either unmute yourself and put your hand up and you can ask them directly, which would be great, or do put them in the chat down the side.
I see one question from Michael, who's asked about end-tidal oxygen, and it's your role pre-hospital. That's a really interesting point. I'm not aware of any service worldwide that is measuring end-tidal oxygen, either in the ED setting or in the pre-hospital setting. I have no experience of it, so I don't feel qualified to comment. I can certainly understand the theoretical advantage, but I'd welcome, is there anybody else in the room that has experience of this or would like to comment? Libby, do you have experience of it? Is that something in your practice at all? Or?
No, I wanted to check that wasn't a typo and he didn't mean end-tidal CO2 rather than O2. But
end-tidal CO2, if that was meant, absolutely. I don't think there's any doubt that end-tidal CO2 is a standard of care, but I'm assuming he's applying to end-tidal oxygen, which certainly is used in other places and in theatre. So I'm assuming that wasn't a typo, and I think it's a very valid question.
Absolutely. Michael's been very active at sort of engaging with everybody. So Irene is saying, I'd like to know your opinion regarding establishing a UK emergency medicine airway registry. And she discloses it's actually a project she's working on herself.
I mean, I think I'm a firm believer in registries as a way of finding key research questions. I think if we look at across critical care, one of the tenets defining a trauma centre is you enter registry data. One of the tenets for an out-of-hospital cardiac arrest centre is you enter data. I think if you are going to take intubation in your department, you need a registry, you need standards, you need key performance indicators, and to benchmark those, you really need a national registry. So absolutely I do. Whether it's the most important thing or whether it's a national priority for funding is a different matter. But I'm really pleased that you're doing that, Irene, and thank you for the work you're putting in.
And then there's something from, I'm not sure which part becomes the first name before it's all one name, Felipuriolia, who looks like they're offering to do a talk about BVM for us. But she's saying,
we'd love you to do a talk at BVM, and it's very kind for you to offer.
Well, Philippe
will be joining us soon.
Would you agree that when pre-oxygenating with a BVM, there's a significant difference between the flow of oxygen between compressing the face mask or just passing over the face without assisting the ventilation?
Short answer, yes, but I think this depends on the flow rates and how you're bagging the patient and whether the patient's still breathing or paralysed, and you're going to influence that with your PEEP valve.
She's having a guide. She didn't actually offer to do the talk, but yeah, I was just thinking it'd be great. So it's just a little bit more coming back to actually, low resource settings, having to discuss with family about financial resources for the private setting and a bed available or government setting before you're able to intubate. And I know family and making these decisions with the family is quite a big issue for you as well, working in the in Qatar at the moment as well, isn't it, Tim?
I mean, for sure. I think people overestimate the benefit of a ventilator. I think that's true of doctors and relatives. People often see intensive care as a sort of semi-magical black box where you tip somebody with critical illness in and they miraculously come out the other end, walking and talking, and the media, television all drive this idea. The outcome from cardiac arrest and TV series is about 90% CPC 1 and 2. The outcome from cardiac arrest in reality is about 8% CPC 1 or 2. And unreasonable expectations lead to unreasonable behaviour. And one of the groups I did mention was GCS less than 8. I think one of the key studies we need is if you've got somebody that's ventilating themselves to normoxia and normcapnia, and they've not been eating and drinking and they're not vomiting, and they've got a GCS of under 8, does the act of intubation actually offer them any advantage? I know personally I've stopped intubating a lot of comatose strokes where they're ventilating themselves to normal oxygen, normal capnia, arguing that putting a tube down means drugs, that's dangerous, means the act of intubation, that's dangerous, and then exposes them to a risk of ventilator-associated pneumonia of about 3% away. I'd be really interested to know what other people think of that. I know for myself, based on very little evidence, and I did look really hard for evidence on this, I don't use GCS as a key determinant of whether I intubate patients or not.
There was a chat much earlier on in your talk, and it was from Deb Kumar, who's from up in the Northwest, because he introduced himself nicely at the beginning, saying that ED's become too task focused and actually, resulting in the airway trauma, and it's all about that bit rather than actually thinking about the wider picture, which is key. And Adil saying here, unreasonable behavior due to unrealistic expectations. Any more questions for Tim? Otherwise, we can let you all. Oh, there we go. Here's Bish. I'm Bish. I'm an ED FY4 looking at ED versus ICM. Or both. That's what we like. A bit of both, definitely. How do you get to find intubation as a skill gets used in ED versus having to ask ITU to decide, give permission? Probably because of ITU bed availability in the UK versus USA. Seems like it varies in different regions. Where are you joining us from, Bish? Are you joining us from the UK or from the USA? And I know we have some consultants on the call from other hospitals in the UK who'll be able to jump in and make comments on this too. But Tim, who do you think should be doing the intubation?
I think it's not your background that's important. It's your skill, your ability to be trained, your training, your maintenance of skills. So your involvement in doing the procedure, your involvement in simulating for the procedure. I certainly think you can't be intubating if you're doing it once or twice a year or whatever. The minimum numbers you need to keep your skills up are guesswork at the moment. We don't really know. I've worked with intensivists who are anaesthetists who are brilliant with airways, but I've equally worked with intensivists who have a background in emergency medicine or acute medicine who through their perseverance have become brilliant with airways. So I think to define a particular motor skill, and I say at the outset, well, the motor skill is important. I think far more important is selecting the patients on whom you perform that motor skill is more important. And I work pre-hospital, and one of the absolute joys of working pre-hospital is I share my time with colleagues from anaesthesia, emergency medicine, critical care and other specialties. I think the debate of comparing performance of Dr. X to Dr. Y is disingenuous and potentially destructive. What we need to do is to set standards of care and ensure that all of us achieve those standards of care, be that for intubation, placing a chest tube, front of neck access, or even just putting a cannula in. Now, I certainly don't think all emergency physicians should be forced to intubate. I've seen it described as a core skill. It's a core skill if you're going to work in resus. It's certainly not a core skill if you want to spend your time dealing with minor injuries. And we are a diverse specialty. And similarly, I've got friends in anaesthesia that have now dedicated their life to pain and pain clinics, and they haven't intubated for some years either.
And I think that's what the challenge is coming up for all the Royal Colleges, certainly in the UK, and I'm sure around the world, is this thing about getting people signed off as competencies. You're expected to do things as part of your training, but does that mean you can then carry on pretending you can do it forever? Whereas I haven't intubated somebody for several years now because I don't spend much time in resus. So I would do it if it was me and nobody else possibly available, but it wouldn't be the right thing to do and it wouldn't be the appropriate approach. So I think it really depends on where you want to work, and I think people choose where they want to work as well because of that, both nationally and internationally, because there's different opportunities in different hospitals. And where I work, ITU do a large number of the intubations, but actually they don't do all of them, and a couple of my colleagues on this call definitely do some of them, if they feel it's the appropriate thing to do, and we try to make sure those trainees have that opportunity.
I think the other key thing here is intubation is not the act of putting a bit of plastic between the vocal cords of a human. Intubation is a team, and only one of those people will be putting the tube down. Other people will be giving drugs, watching, monitoring, Other people will be part of the debate and selection and the resuscitation process. I think the emphasis should not just be on I'm the person that holds the plastic, but on the team and the team making that team work better. You know, if you've got a high intubation that's got anatomically easy and physiologically difficult, then the team leader leading the physiological optimization of the patient probably holds more key to safety than the person placing the tracheal tube.
Yeah, absolutely. And I think that's where pre-hospital checklists come in, but actually you get tension, don't you, with checklists, and depending on who's using the checklist and people's innate skills and things. But I'm certainly very happy to stand at the end of a bed with a checklist and give my 2 pence and oversee. But I know the anaesthetist will sometimes come down and not use it and crack on, and they've got different skills and different experience. There's a question here from Jo Organ, and she's saying, given the number of changes from the originally described techniques, is it time to move away from calling this RSI? Pre-hospital emergency anaesthesia, FEAR, seems to be gaining popularity out of hospital. I certainly know it is in some of the air ambulances not far away from where I am. Thoughts on that, Tim, or anybody else?
Personally, it's not a debate that excites me with a great deal of passion. I know that the original technique was described as rapid sequence induction. Our American colleagues decided that that didn't have emphasis on oxygenation before intubation and called it rapid sequence intubation. The single technique of RSI has arguably evolved into a number of techniques diversely applied and customized to match the needs of the patient. Now, the way you intubate somebody pre-hospital would be different to ED because of the time constraints. The need to intubate someone to get to theatre because they need the belly opening because they've been stabbed is going to be different to operating on a, I don't know, AAA or whatever, or an overdose. So I think to have one term encompassing anaesthesia performed outside the operating theatre or anaesthesia for acute care as opposed to elective anaesthesia is important, because the two techniques are fundamentally different. What you call it, I don't care, actually. You know, I can understand there's different terminology, and I can see it exciting a debate, but for me what matters is the people practicing the art and science of anaesthesia outside the operating room understand the risks and benefits and choices. And to me, you've got, yep, I'm an elective patient, I'm prepared, my stomach's empty, maybe I've had some pre-medication, maybe I haven't, I have my bowel prepared, versus I am an unselected, undifferentiated patient that didn't wake up this morning thinking I was going to need an anaesthetic. And I think that's the fundamental difference. And what you call it, I think if people want to change it, there's a consensus they will. I've not been involved in any of that debate.
Yeah, I mean, semantics is always interesting, isn't it? And how it means a lot to some people and not to others, and getting the job done at the end of the day. There's one more from, two more questions and then we'll call it to a close. So one from Michael Templeton saying, what about paramedics? In the UK, it's now impossible for paramedics to get the skills maintained. Elsewhere, it is encouraged as part of critical care, but the standards are variable. What is the way forwards? Improving paramedic access and training, withdrawing the skill entirely across the globe?
So I think number one, across the globe is not going to apply. I think there's different skills for different people and different solutions for different countries. So where I trained in Australia, there was a group of paramedics, MICA, mobile intensive care units, and they intubated, they did drug assisted intubation, they placed central lines, and they were very, very good at it. And there's plenty of literature that shows it's not the adjective that describes you or the career that describes you. It's the number, it's the training you do and the frequency with which you do it. I do not think training every paramedic in the act of drug-assisted intubation in the UK setting is useful, because the average paramedic will require those skills infrequently. I absolutely think supraglottic airway is a core skill for everybody, and absolutely think bag valve mask is a core skill. And the same would be true of emergency physicians. I think in the UK setting, to have every emergency physician trained and practicing intubation means that the number of intubations is going to be inadequate to maintain experience on all of them. So I do think they should all be able to put down supraglottic airways, but I think in the end, each hospital has to decide. So where I trained, as an emergency physician, I was expected to run every cardiac arrest in the hospital. And that's where I got interested in this. If someone on ward 4D had a cardiac arrest, my job as the emergency physician was to go up there. The intensivist didn't leave ICU and the anaesthetist didn't leave theatre. In the UK, sometimes it's the anaesthesia team that do that, and sometimes it's the intensive care team, and variably around the UK. I think to have a rigid rule to force everybody to practice in the same way rather than adapt locally is to court disaster. I think each hospital and country needs to adapt based on its numbers, its experience, its training, and its governance structure.
And I think hopefully with the move to using supraglottic airways in cardiac arrest, we know we've removed this need to train everybody to do intubation for those situations, and therefore we can just think about those more critical care paramedics who are doing the advanced situations, or for anybody across any of the specialties, you know, and actually who really needs the intubation skill versus the supraglottic airway skill. Two rapid questions. As an ultrasound person as well, ultrasound visualization of the trachea during intubation as a method of avoiding esophageal intubation on difficult airways, yes or no?
Sometimes. So an example, a little while ago, I had a patient that came in with thyroid cancer. It made it almost impossible to identify anything anatomical at the front. They were clearly going to be a difficult airway, and they deteriorated extremely rapidly. Now, ideally, I would have called an anaesthetist to do a fibre optic, but there was not time. In that particular case, being familiar with ultrasound, using the ultrasound, one, to identify where I would do a crike if I had to, and two, to visualise the intubation was useful. I don't do it all the time. It's something I do rarely. I practice it, I teach it, but I don't think this is an integral part of advanced airway care. There's a comment about front of neck access. Yeah. I mean, front of neck access has become much rarer. And since I started working in departments with direct laryngoscopy, video laryngoscopy, I haven't done a crike. Whereas if I go back to the 90s and noughties, I was involved in 11. I was in a room or party and led on 3, 4. You know, it's something that I think is becoming rarer and rarer. It's something I still practice. You know, when I'm driving to work, I still run through it pretty much every shift. I close my eyes and imagine it, because I am reaching a point where it's, you know, it's nearly 20 years since 15 years since I did one.
Brilliant. I think we should call it to a close there. Thank you so much, Tim. There's lots of thanks on the chat there for all the pearls of wisdom and the time and effort it's taken into preparing this and sharing it with everybody. So we all really appreciate it. And you've got 40 people nearly still right through to the end. We've been going for an hour and nearly 20 minutes, which is really fantastic and testament to the quality of the content. So thank you all for joining us. We really appreciate it. And it's great to have you here. 2 weeks time, Tim's going to be back talking about lactate, the most useful biomarker in critical illness, yes or no. And if you want to catch up with any of our other webinars previously, then we will post the link for that on the side there. And then finally, for any of you who are interested in studying a little bit more and taking your knowledge of emergency medicine, resuscitation medicine to a higher level, and are not currently aware of our MSc program that we run through Queen Mary's University. This is a distance learning MSc. We've got colleagues on it today from Nigeria and other parts of the world, and we have plenty of people from the UK who join too, and it's for paramedics, nurses, and emergency medicine doctors, or doctors from other specialties too who are particularly interested in it. So do check all of that out on our web pages, and again, those are in the links there. Thank you all very much, especially thank you to Tim. Hope you've got a large glass of water. You must be feeling parched, and we'll speak soon. Thank you, everyone.
Take care, guys. Have yourself a wonderful evening, and thank you for giving us your time. And come study with us. The MSc is the most fun you're going to have outside the resus room. Take care.